Hello, MSAT students. Welcome to your online lecture for abdominal pathologies. As always, I'm going to start with abdominal anatomy and then work our way through the different types of pathologies that are going to be probably most prevalent in the field of athletic training. I think it's also important to kind of think about what type of trauma occurs within the abdominal region. So most often it's going to be traumatic in nature, like a direct blow from a helmet into the abdominal cavity. But it's certainly pathologies or diseases can also plague the abdominal cavity via bacterial infection or viral infection and create what we call our itises or inflammatory responses. So we're going to talk through some of those illnesses, such as like mononucleosis, for example, which may have an impact on our abdominal region. But let's just start with the basics. The abdominal cavity, if you don't know this, is one of the largest hollow spaces within the actual human body. It is formed superiorly, or its upper boundary is the diaphragm. So I'll draw that in there. Its upper boundary is the diaphragm. Posteriorly, it is supported by the vertebral column or the spine. Inferiorly, we can look at this and we can say that its lower boundary is the upper plane of the pelvic cavity. So it's going to sit nicely within those iliac crest and then also that kind of pubic symphysis. From a muscle standpoint, laterally, its borders are the external internal obliques. And then anteriorly, what we would say are muscles overlaying that are going to be the rectus abdominis muscles, right? The transverse abdominis muscles as well. So we have a really tight-knit structure, which is encased by our diaphragm superiorly, our pelvis inferiorly, and then laterally, muscularly by the internal and external obliques. The abdominal cavity is important because it contains our major internal organs, and we'll talk through those. But then it also contains a lot of the organs that are housed within our digestive tract. And so we're going to talk through each of those anatomical structures independently. So there are several different ways to kind of break up the abdominal cavity. The most common way in the field of athletic training is into what we call are the four quadrants or the four abdominal quadrants. And you can see those four abdominal quadrants listed here. Within each of these abdominal quadrants lives what we would call the majority of some specific internal organs. So this UR stands for upper right quadrant, and the UL stands for upper left quadrant. And then you can kind of guesstimate what this would be: lower right and then lower left quadrant. So as you palpate, you want to be very systematic in the ways in which you do that. Typically, we're going to start away from the pain and then move in toward the pain during our palpation of the abdominal region. But the four abdominal quadrants are important because it allows us to know like when they're pointing to an area of pain, we can at least kind of in our mind be thinking about which internal organs might be plagued, might be injured, might be compromised based on the location of pain. So in the upper right quadrant, we have the liver. It's probably the most commonly injured internal organ in the abdominal cavity, minus the appendix, which is housed in the lower right quadrant. In the upper left quadrant of focus would be the kidney and the spleen. And then in the lower left quadrant, most often you have the reproductive organs, but particularly the bladder is most often compromised, and that descending colon as well. So we have major internal organs that are housed within each of the upper quadrants, and I've kind of just highlighted the ones that are probably most commonly injured in each of the quadrants so that at least you can be thinking about that from an injury perspective. But we certainly should also consider if a patient's having issues with breathing and they take a blow to the upper right or upper left quadrant, that the lung might be compromised. And in our thoracic lecture, we talked a lot about hemo and pneumothorax. So it is very possible that a patient could take a blow to the upper right or upper left quadrant and have a pneumothorax in the very low portion of the lung on either side. So most often in the field of athletic training, we typically refer to or dissect or assess the abdominal region by the four abdominal quadrants. But there are the abdominal region just in general in healthcare can also be broken down into what we call are the 9 gastric regions. So I'm going to skip to this area. In the upper right hand corner of the slide, you will see that the abdominal region is broken up into the 9 quadrants here. or 9 quadrant or gastric regions is what I should say. And then over here, the 4 quadrants, right? And so we have the right upper quadrant, left upper quadrant, right lower, and then left lower, right? And maybe use this as a quiz. What things are housed in the right upper, left lower, right lower? Maybe use that as a quiz, write it down really quick. And then something that's probably not as intuitive to us is in the field of athletic training, but certainly warrants study, are the 9 gastric regions. So if I could draw this out, I would do this, and then I would essentially do this. And again, we're going to kind of transpose that there. So the upper center region is going to be called the epigastric region, which you can see there. Center would be the umbilical, which makes sense because what is it next to, or right, what is it over? The umbilicus or the belly button. The lower is most often referred to as hypo, which means below, gastric, which means stomach. So this is the hypogastric region. So those are the ones that are on the image. But I still also wanted you to know the other regions that exist within the 9 gastric regions. So to the patient's left would be the left hypochondriac region. So hypochondriac region. In the center would be the left lumbar. Why do you think that is? Region. It's at the lumbar level. On the left lower is going to be the left iliac region. Why is that? It's sitting right at the ilium. Okay, and then we just have the same thing on the right side, right? So right hypochondriac, right lumbar region, and then we have the right iliac region. So you can see all of the 9 different gastric regions, and this allows us to be a little bit more specific with the things, the internal structures that are going to live there. And I'll give you a few examples. In the right hypochondriac region, we have the liver. Interestingly enough, in the epigastric region, we have the liver. And then more interestingly enough, in the left hypochondriac region, we also have the liver. So what does that say about the liver? If we look down here in this image, what do we see? It's a large internal organ, right? That is absolutely going to span across all 3 regions, right? And so if we just look at our quadrant approach, most often we just place the liver in the right upper quadrant, but it is possible to have damage to the liver that causes pain over on the left side, right? Because we can see how that liver kind of spans over into the epigastric region and then also the left hypochondriac region as well. Another example of that is in the right hypochondriac region, we have the right kidney. In the left hypochondriac region, guess what we have? The left kidney. But then, interestingly enough, that left kidney, guess where it's also going to live? It's also going to live in the left lumbar region. So that left kidney will live there, and that right kidney will live here. So we can see how we're even more specific in our approach, that breaking the abdominal cavity down into the 9 regions allows us to really be specific with the anatomical structures that we are palpating. Your textbook will have all of the gastric regions with all of the internal anatomical structures. So my expectation is that you will know exactly what lives in each of those regions. And as we get ready to palpate in lab, this will be an important kind of cornerstone, keystone approach to really nailing the palpation of the anatomy. So on this side, we're going to be talking about referral pain patterns, and I kind of want to define what referred pain is. So when we think about referred pain, what I am referring to is any pain that is not in the location of the actual injury, right? So an example of this would be if I take a blow to my right upper quadrant and I have pain in my left shoulder, that would be referred pain. So it's pain that is not in the location of the actual injury. And I think this is important, and it's a time where we should spend kind of talking about the abdominal cavity just a little bit more. So the abdominal cavity we talked about, it can be broken down into quadrants. It can also be broken down into 9 gastric regions. And within each of those quadrants, or within each of those 9 gastric regions, we said that there are internal or abdominal organs that are kind of housed within each of them, right? But one of the things that I didn't mention earlier on, and I think that's just because I wanted you to understand the anatomy, is that the abdominal cavity is lined by a membrane known as the peritoneum. So the peritoneum, let's go ahead and put that on here. It's lined by the peritoneum. It's a membrane that not only covers the inside wall of the abdominal cavity, but also covers every organ within the actual abdominal cavity itself. So let's dive a little bit. There are two types of peritoneums that are housed within the abdominal cavity. If we're talking about the peritoneum that lines the entire abdominal wall, then we refer to this as the parietal. Okay, the parietal peritoneum. If referring to a peritoneum that lines the actual organs itself, then we call that a visceral peritoneum. And those are different, right? This is going to be very specific. We have a liver visceral peritoneum. We have a kidney visceral peritoneum, right? Whereas the parietal peritoneum is just going to line the entire cavity. And this is important to understand because when we think about referred pain patterns, one of the things that we have to think about is that we have these two different types of membrane, both surrounding the entire cavity, but then also surrounding the organ. And sometimes what we see in referred pain patterns is that because that parietal or visceral peritoneum may expand into other anatomical structures or may be connected to other membranous structures throughout, that we certainly can have referred pain patterns or patterns that don't necessarily make sense with what we actually saw or what the athlete actually reports. So if we keep that in mind, that in fact some of this membranous tissue may be connected to other anatomical structures throughout the body, anytime we have a patient who reports shoulder pain, right, or back pain, we should often be assessing, at least doing a quick assessment of the abdominal cavity. So what you see over here on this part of the slide are common referred pain pattern for specific types of pathologies that we're actually going to see in the field of athletic training. So the first one I'm going to point to is over here in the upper right-hand corner of my screen, at least, and that's when a patient has an injury to the diaphragm. Most often, if we were to draw the diaphragm in, it would be kind of right in this area, right? So you would expect a centralized pain just underneath the kind of rib cage, right? But what you can see is that when a patient has a diaphragmatic issue, most often they might have trouble breathing, but they're also going to report pain in the kind of neck region and in the shoulder region. So you can see that there. So yes, if a patient takes a blow to kind of the rib cage, they might be complaining of an anterior lateral shoulder pain. And you're like, where is this coming from? You would have to think back to the diaphragm. And again, that has to do with the membranous peritoneum or the tissues or the way in which the diaphragm inserts within the thoracic cavity or in the abdominal cavity, right? Because it's connecting both pieces. Another site of referred pain that often tricks students is liver pain. So when we're thinking about liver pain, what are we looking at in this particular graph? Where is that patient going to report pain that's kind of unexpected? Good. If you said kind of the upper right shoulder, which could be both posterior and anterior, you would be correct, right? You can also see on this particular image in the kind of lower left back as well, you might have some referred liver pain as well. So again, you have an injury way low on the abdominal region on the upper right-hand side, right, in the upper right-hand quadrant, but the referred pain is going to be to the shoulder. And so again, that's what trips up our students. And oftentimes it will go undiagnosed. Patient may bleed a little bit, continue to bleed. And then eventually once they have enough blood in the actual abdominal cavity, then we palpate it and we feel it and we've missed it. So make sure you're understanding the referred pain patterns for specific types of pathologies that you're often going to see. Another one that you'll see oftentimes is gastric pain. So we call it gastritis, where there's an inflammation of the stomach. That's often going to be in that kind of lower left quadrant. Or you could say left kind of iliac region if you're looking at the 9 gastric regions. So it will become important to just make sure you understand referred pain patterns, right? If you have on this one, oh yeah, it's there. Okay, if you have a splenic injury, which the spleen lives in that upper left-hand quadrant, you'll have what we call is a positive Kerr's sign. So positive Kerr's sign is where you have referred pain to the upper left shoulder. So again, some common pathologies that you'll see, you can see different referred pain patterns, and that has to do with, number one, the tissue that lines the actual abdominal cavity, and how that tissue may extend into other areas of the human body and how it may then create, right, these referred pain patterns for our patients. So this is a really good chart to kind of use as you start thinking about how do we differentially diagnose pathologies that happen in the abdominal cavity. And oh my goodness, is anyone else getting overwhelmed by this? I certainly did the first time that I looked at it. So I'm going to bring it a little bit closer and draw it into us. So here's how I would interpret this chart. So if we have a blow, right? If a patient receives a blow to any of these 9 gastric regions, does that make sense? So any of the 9 gastric regions. So they've put gastric regions in there, and then they've also used quadrant language. I'm hoping you all are seeing that. But if a patient takes a blow to any of these regions, so example, if a patient takes a blow to the upper right quadrant, right, or the upper hypochondriac region on the right side, then, or complains of pain, then we have to start thinking about any of these pathologies, right? If a patient is complaining of pain in the hypogastric region, then we have to start thinking about any of these inherent pathologies, right? The more that we look at the upper portion of this chart, the more we can say these are injuries that we're going to see most often in the field of athletic training. They're going to be more traumatic in nature, right? The more that we look at the second half of this chart, the more that we say, okay, these are going to be, most of these are going to be lifelong diseases that we're going to have to refer out to receive treatment for, right? Examples would be things like ovarian cysts or mass, which will refer pain to the right lumbar region, right? You can look at diverticulitis, which would obviously be a pathology to the intestines, right? So we're gonna refer out and figure out dietary things. But as you look at this chart, there's so many things that can go wrong in the abdominal region. So knowing which things, remember I said this, knowing which things will live in each of the quadrants becomes extremely important. One thing on here that I would love to highlight and that we see oftentimes in younger patients is appendicitis. And so early on, when they first get plagued by appendicitis, they're going to have referred pain centrally in the umbilical region. But as the inflammatory condition is allowed to continue to grow, then we see that the pain progresses and moves distal into the right lower quadrant. So we can see how owning this, at least in some way or some regards, is extremely important to understanding predictability of pathology. Finally, what I would like to say is you do need to know the major organs for the exam. There have been drag and drops on the exam where you have to drag specific organs into each of the 9 gastric regions or 4 abdominal quadrants. So this is an extremely important point that I'm hitting, which is why I'm spending more time here than I normally would. So as we consider pathologies of the abdominal cavity, really what we want to do is, from a history perspective, we're going to just think through a few different types of questions that we're going to ask the patient. So the first one is just location of pain. And we've kind of hit this multiple times on different slides, right? The location of pain will kind of be indicative of the different pathologies. We've mentioned most of those that the patient might be experiencing. So that'll help you as you're thinking through the differential diagnosis part of this. The next thing is what type of pain is it, right? So is it insidious, meaning it just came on, or is it as a result of traumatic pathology, right? Is it more focal, localized, or is it diffuse and not in one area? Is there referred pain, right? So not only do they have pain in the abdominal region, but then also where else do they have pain? And how does that referred pain pattern link up to what might actually be involved? How consistent is the pain, right? Is it all day? Is it only when you bend over? Is it only when you stretch the abdominal region? And then in terms of postural influences, is there like a position of comfort or a position that will exacerbate the signs and symptoms a little bit more? And does the patient have a fever? And this is going to be key. Remember earlier on in this lecture, I alluded to the fact that you can have an inflammatory response happening, like a cholecystitis, for example, and appendicitis. Most of those are going to also be associated with some type of fever. So essentially what I'm saying is, does the patient have an infection? And then last but not least would be, is the patient complaining of chest pain? And if that chest pain is linked to bony pathology, or if it's linked to the actual heart, which is located in the thoracic cavity. So these are the questions, like if we think about a checklist of historical questions that we're going to ask a patient who takes a blow to the abdominal region, this would be the top 6 questions that I would ask in my history. So the first pathology that we're going to talk about is a ruptured spleen. Before we can talk about the trauma that can happen to the spleen, we kind of have to understand anatomically what the spleen does. It has a few important functions. The first one is it is one of the largest lymphatic organs. And so just by nature, one of the things that it does is it really helps in fighting any kind of invading germs that enter into the bloodstream, right? So the spleen itself contains these infection-fighting white blood cells. Their major role is to really fight off any of those germs, bacteria, viruses, etc., that will enter into the bloodstream. The other thing that it does is it really works to control the level of blood cells. So in particular, it helps to control the level of white blood cells, red blood cells, and platelets. So essentially, like when we get sick, for example, it's responsible for either causing an increase in the white blood cells to kind of help cause phagocytosis and eat away at the bacteria. In addition to that, it's going to kind of filter or screen, for lack of better words, or remove any old or damaged red blood cells. And so when the spleen doesn't work properly, or when there's injury to the spleen, it may start to remove healthy blood cells, right? And that can lead to a lot of things. One of those things is an example of that would be like a condition called anemia, which all of us have heard. So if we have an injury or compromise to the spleen, oftentimes we see that not only does it remove the damaged blood cells, but it will start to remove, won't be able to identify damaged or healthy, and it will start to remove the healthy blood cells and create anemia. So one of the reasons we can see an anemic patient oftentimes might be as a result of some dysfunction to the spleen. Hopefully that makes a little bit of sense. So we can see that the spleen plays a major role, not just in filtering damaged blood cells, but also controlling the levels of the integral blood cells within the body. And so when there's injury, when there's bleeding or bruising, a lot of times we see compromise to the ability of the spleen to do what it's supposed to do. Now, the spleen, as we said in the image of the quadrants or of the 9 gastric regions, is located in that kind of upper left-hand quadrant, right? And so essentially when there's any kind of blow to the upper left-hand quadrant, we're concerned, right? The spleen itself protrudes below the ribs and can become exposed, particularly right underneath that rib cage on the upper left-hand quadrant. And so what's the etiology? How does this happen? A severe abdominal blow, right, to the upper left-hand quadrant, which causes either a laceration or internal bleeding from the spleen. The other way that it can happen is through some type of systemic infection. So let's say a bacteria is allowed to enter into the bloodstream and into the spleen, then it can become infected. And then last but definitely not least, anytime you fall on a ball on the left-hand side, so in particular like harder balls such as basketball, you can see a rupturing or a laceration of the spleen. So then what are the signs and symptoms that are truly related to splenic injuries, right? The first one's going to be an abdominal rigidity. So what do I mean by that? It means that if we have a splenic rupture or a splenic laceration, the spleen will essentially leak or ooze blood into the upper left-hand quadrant, making the abdominal cavity very hard to touch. In addition to that, it may, depending on the amount of blood in the abdominal cavity, can kind of compress, right, on the phrenic nerve, for example, or the splenic artery, for example. And so then it can also cause nausea and vomiting if there's too much blood, right? Because then it causes the esophagus to kind of do its thing. And so you'll vomit blood potentially. The patient will have referred pain to the upper left shoulder. We call that a positive Kerr's sign. They most likely, unless we control the bleeding and identify it, will go into shock and have low blood pressure. And they might actually have tachycardia, which is an increase in heart rate. And that's intentional to make up for the blood that is being lost. So this can become a medical emergency. The scary part about splenic ruptures is especially, or lacerations, is if the laceration is very small, the bleed may be very slow. So the symptoms may take a very long time to manifest themselves. That's why it's important to really look for other signs and symptoms and referred pain pathways. So when we have a patient who's presenting with the common signs and symptoms that we discussed on the other side, what do we kind of do for that? We're referring to the emergency department right away. And most often they're going to treat for shock. And then the recommendation so that we can redivert the blood flow and assist the circulatory system is to lay that patient flat or elevate the torso as much as is possible. The biggest thing we're going to do is just control the body temperature and reassure the patient and get them to the ED right away so that they can go into surgery. In terms of prevention, if you have a patient who has, let's say, an inflamed spleen or an inflamed kidney, which will live directly posterior to the actual spleen itself, so mononucleosis would be an example of that, we're going to limit them from participation because any direct blow can cause a splenic rupture or a splenic laceration. So if a patient suffers from a splenic rupture or laceration, then it's usually 4 to 6 weeks with no practice. And then they'll have to do a follow-up ultrasound assessment, which you will see here. The next common pathology that we see oftentimes is a kidney contusion. And so just as you can see kind of in this image, I'm just going to blow this up just a little bit so you can actually see it a little bit better. As you can see in this image, the right kidney is going to sit a little bit lower than the left, and most oftentimes we'll see the right kidney being injured. But when we think about like true function of the kidneys, like what do they do exactly? Essentially what they do is they filter blood. So they are filters of blood. So we'll say that there. So they're filters of blood. And essentially what they do is about every minute, they're filtering about a half a cup of blood every minute or so. And what they're doing is essentially removing any waste or any extra water from the blood. And that extra waste and that extra water, guess what it becomes? Guess what we excrete it as? Yeah, you got it, right? We excrete it as urine. So the kidneys, think about it this way. We're going to trace kind of how this all happens. So the kidneys essentially, right? They're here. So one here. Essentially what they do is, as we said, they remove waste and extra water to make urine. And so essentially that urine then moves from the kidneys, right? Does that make sense? Through the ureters, you can see that there, into the bladder. And so then the bladder will store those waste, and guess what will happen? Essentially that bladder will contract to excrete any urine in the body. And this is really known as, these anatomical structures as a whole, what we call it, the urinary tract, right? And so the kidneys are extremely important in filtration, in particular allowing us to excrete external objects from our body that might be harmful. So as we go back, anytime we have a kidney contusion, oftentimes that will reduce their ability to filter or reduce the amount of blood being filtered every minute. Remember, we said about a half a cup of blood is being filtered every minute. And so that filtering, what am I thinking? Might slow down just a tad with trauma. But essentially the mechanism of injury is going to be a blow to the mid-back. So we're talking like lower thoracic, upper lumbar spine region. We see this most often in which sport? Yeah, right. So football, rugby, maybe lacrosse if you get a stick there. The signs and symptoms are going to be more posteriorly related than abdominally or anteriorly related. So patient might have back rigidity, especially if that kidney is lacerated and is bleeding out into the peritoneum. You can have nausea or vomiting. Most patients will go into shock depending on if there is an actual laceration. And you're going to have hematuria, which is what? Blood in the urine, right? So you'll have to do a urinalysis or a urine test to see that. Usually it's trace, meaning you can't see it to the visible eye. If you notice bruising on the posterior aspect of the low back, and the patient is presenting with back rigidity, some nausea and or vomiting, then that's an immediate referral to the emergency department, especially if you think it's ruptured. The patient, typically what I'll have them do is just go to the bathroom, urinate, and see if they see kind of blood specks. But big thing with a right kidney bruise is that you actually want to rule out a liver injury, and then with a left kidney bruise, you want to rule out a splenic injury, right? Because The kidneys just live just directly posterior to that. And if the force was great enough to cause a kidney contusion or rupture, then most likely it transferred force to the liver and indirectly could be injured on the right side, or the spleen, which could be indirectly injured on the left side. So we always want to double check the anterior internal organs when we can. So the next pathology that we often see in mostly like sparring, boxing, kickboxing is what we call a solar plexus pathology, or really commonly termed a celiac injury. So the question might be on the exam, a celiac injury is also known as and you could say solar plexus injury, but this is like quote unquote when the patient gets their wind knocked out of them. But I think scientifically what we really have to understand is like, what in the world is the solar plexus or the celiac plexus? And so a greater look at this image here will allow us to kind of see that and appreciate that probably a little bit better. So this area right here represents the celiac plexus. And when we think about the celiac plexus, it's this complex network of nerves kind of located in the abdomen. In particular, it kind of sits in between the stomach and the diaphragm. So like right in the sweet spot, right in that central portion, like kind of if I were to draw the rib cage in there, it's sitting like right in here, just beneath the xiphoid process, if I could kind of term it. So in essence, when we see injuries to this, if there's like a punch to that area or a kick to that area or a strike to that region of the stomach, and it causes the diaphragm to essentially spasm. And so when the diaphragm spasms, it causes an array of signs and symptoms. One of those signs and symptoms is going to be what? A sudden loss of breath or the inability to catch their breath, because remember, the diaphragm will expand to allow us to bring air in, and then it will kind of relax or pull down to allow us to release the air. And so when that's spasming, we have a harder or more difficult time really truly catching our breath. So in terms of etiology, now that you know where that solar plexus or celiac plexus is located, you know that any blow to that kind of central space, either by punch or kick or falling onto a hard object, will then cause the diaphragm secondarily to spasm. And then as a result, that patient suffers from difficulty in breathing and bringing in oxygen, right? So what are the signs and symptoms? Directly after the blow to the celiac or solar plexus, the patient may have a startled appearance. They're going to look shocked because they won't be able to catch their breath. Like they literally will not be able to catch their breath. What we know about these patients is once they're able to sustain breathing, normative breathing, they often have referred pain to the abdominal region and the chest because it's located in that sweet spot, right? So for care, what our major role is going to be is kind of like Lamaze breathing with pregnant women, in that our major role is going to be to restore normative breathing. So having them breathe in through their nose and out through their nose to restore breathing. The recommendation is if you can't get them to catch their breath after 4 to 6 cycles, then you're gonna suspect not only do they have a solar plexus or celiac injury, but they might actually have some internal organ damage. Most often, it's going to be the liver based on the location of the solar plexus or celiac plexus. So this is really common, believe it or not, in court sports like basketball, where you have a jump ball, for example, patient falls down onto the ball and directly hits that solar plexus or celiac plexus. So very common to see in court sports, very common to see in sports where there is sparring occurring. The next type of injury that can occur, some of you are probably thinking, oh my goodness, does this really happen? The answer is yes, you can have a ruptured bladder. So just in general, if we're thinking about the function of the urinary bladder, remember that it's a hollow organ that receives all of the waste, right, and fluid from the ureters, and the ureters receive the waste that have been filtered from the kidneys, right? So if I drew those in, we have that process. And then the urinary bladder is going to kind of store that urine before it's disposed of in the process of urination, right? And so I think that makes a lot of sense. But if we have a full bladder, so how many of you have ever been like in class and you're sitting there and you're just letting your bladder expand and it's filling and filling and filling with urine until you have to excrete it, right? Some of you I've seen run out of the classroom to go to the bathroom and then you come back. So oftentimes with athletes, they may feel the same way, like we're getting ready to participate. I can't go to the bathroom. But the highest risk individuals at risk for rupturing a bladder are those that participate in sport with a full bladder. So preventative wise, the main thing that we're going to have those patients do or our athletes do is urinate before or prior to activity, in particular activity that is going to be contact. If you're a cross-country runner and you run a run with a full bladder, the risk of rupturing that bladder is relatively low. If you are an athlete who plays in a contact sport where you are receiving direct blows to the abdominal region, then the risk for rupturing that bladder when the bladder is full is relatively high. This is very rare in young athletes, right? Because the bladder is a stretch-like structure and it has the ability to hold urine without being ruptured. But certainly, if the force is high enough and the bladder is full, certainly can see a ruptured bladder. So how does it actually happen? Some direct blunt force trauma to the pelvis, or you can kind of see it superiorly here through the actual pubic symphysis. So there are two different ways that can actually occur. In terms of the signs and symptoms, the biggest one is going to be the inability to urinate, because if it's ruptured, there's no contraction and therefore we can't expel the urine that has been sitting there, and that creates a concern, right? Because if urine is now allowed to back up into the abdominal cavity, we increase the risk for infection. And so other signs and symptoms besides the inability to urinate is that fluid, those wastes begin to build up. You'll see a lower inferior abdominal rigidity. You'll have blood from the urethra starting to backfill into the abdominal cavity. And so that patient, again, pressure on the nerve, it will cause nausea, vomiting, and eventually shock. Most often sepsis or infection will be the reason for shock. So what do? We're going to x-ray the pubic symphysis. Most often there will be a spreading or a diastasis or separation in the pubic symphysis. But then in addition to that, probably ultrasound diagnostic tools to see if the bladder is actually, or confirm if that the bladder is actually ruptured. So we hope and pray that we don't have a patient with a liver contusion or a liver laceration, because the liver has so many functions in our body, right? When we think about what the liver does, is it holds about 1 pint of the body's blood supply at any given moment. And then more importantly, the liver is going to regulate most of our chemical levels in the blood. It's going to excrete a product that we all know as bile, and that's going to help kind of carry waste products away from the liver, right? And those waste products can be excreted through the kidneys to the ureter, right, for example, and then through the bladder via urination, or certainly the opposite of that through the rectum via a process called defecation, right, or pooping. I'll whisper that. In addition to that, what we see is that it produces bile, which we said helps carry waste away. It also is responsible for producing cholesterol, which also kind of helps special proteins carry fats to the body. It helps convert glucose into glycogen for storage, right? So we can see that the liver plays a major role regulating blood clotting. There's just so many things that the liver does. So any disruption to it, we really have a systemic problem on our hands. So what is the etiology for a liver rupture? Remember that liver is going to live in the upper right quadrant, if we're thinking about it from a quadrant approach, but certainly progresses over, and a portion of that lives in the upper left quadrant, but where it's most exposed is going to be in the upper right quadrant. So any blow to the upper right abdominal cavity, interestingly enough, this is not a hollow organ. It's actually a very filled organ, since it holds a lot of the blood. And so when we tap, it's going to make a dull sound in that area. And we'll do that in lab. Signs and symptoms are going to be the same as with a spleen. The difference is that instead of being referred pain to the upper left shoulder, patient's going to have referred pain to the right scapula, shoulder, and maybe even substernal area. But major things are, key things are where the referred pain is on the right side of the body. So that would be a differential. Patient with upper left shoulder, we're thinking probably spleen. Upper right shoulder, we're probably thinking some sort of liver contusion. If we suspect that, then we're going to refer out. And when we refer out, we're going to refer to the ED, and then we'll do kind of an ultrasonic assessment to see just how much damage we have in the actual liver. So a common pathology in mostly males, high school student athletes too, between the ages of 15 and 25 is appendicitis. And so like the question is like, what is the actual function of the appendix, right? Until recently, most people thought it really didn't serve of benefit. So oftentimes, like when a patient has an appendicitis, which is an inflammation of the appendix, we typically just remove it, right? But there is research to suggest that the appendix may not be useless after all, and oftentimes will help the gut or the gastrointestinal tract in particular kind of heal, particularly after some type of gastrointestinal disease strikes. So an example of that would be like food poisoning, for example, where you've been struggling with diarrhea. What they say ultimately is that the appendix kind of houses this kind of type of lymphatic tissue, which carries white blood cells. And as you know, the white blood cells are needed to fight off infection. So indirectly, that tissue that's stored within the appendix helps fight off infection, particularly after you've gone through a bout of like your food poisoning where the gut has really been impacted by an inflammatory response. So it may actually have some type of benefit. They are actually calling it kind of like a safe house organ in particular. So with that said, the appendicitis is exactly what the name implies. It's an inflammation of the appendix, and that could be due to some sort of infection. It could be lymph swelling in the area or a fecal obstruction. So imagine a world where the rectum gets impacted by fecal matter, and then that fecal matter starts to leak into the abdominal region. Most often it'll grab to the appendix, causing it to become inflamed. And so oftentimes when there is an actual rupture, essentially what you have is this systemic infection taking place. And so signs and symptoms, it could be diffuse, non-specific pain that becomes focal over the next 12 to 18 hours. So a lot of times patients will ignore the pain because they're like, oh, it's no big deal. It's just like a sharp pain, but it goes away and it comes. But then after 12 to 18 hours, what we'll start to see is that infection is allowed to spread. So they develop a mild fever, and then they start to have abdominal rigidity in the lower right quadrant. So that's where the appendix is going to be located, in that lower right quadrant. And so they will have what we call is a positive McBurney's point test, and we'll do that in class so that you can see. They will also be tender to palpation in the iliopsoas region, because that's where it places a kind of a tension about the actual appendix. So what do we do for them? If we have pain in the lower right quadrant that we think is consistent with appendicitis, no food. And the reason for that is because most often they're going into surgery. So we want to make sure that they can go into surgery. If we feed them, they won't be able to, and we're referring out. And typically they go into surgery right away to remove that appendix. Again, remember, you can remove the appendix and it doesn't impact the body negatively, but the research is suggesting that having an appendix helps fight off some of those kind of gastrointestinal diseases that we might encounter over time. So this should be a little bit of a review because we talked about inguinal femoral hernias in the lower extremity, but a review is never a bad thing. So in terms of the kind of mechanism, most often like traditional inguinal hernias typically result as you see down here, some type of protrusion of the small intestine and or fat layer near the pelvic fold or crease. So most often this would be a femoral hernia. We have an indirect inguinal hernia, which is a little bit more proximal. You can see that in terms of where it lives. Or you have a direct inguinal hernia, which is happening near the kind of inguinal canal. Certainly you can have other types of hernias, right? An umbilical hernia, which is most often seen in younger kids, where the belly button will protrude. And then you can have what we call is a what type of hernia? The sports hernia, which would occur a little bit lower, right? Kind of in the inner thigh adductor region. So in terms of how they happen, it can be congenital. They're born that way. Or like, for example, one of my twins, they, with the umbilical cord, they pulled the umbilical cord immediately and then inserted a tube. And so when they took the tube out, that created the umbilical hernia that she now has. It can be acquired through the direct trauma, which is what I mentioned. Sorry about that, everyone. My iPad was about to die. So back to it, acquired or direct trauma. So like an overstretching, for example, overcontraction can also cause that. or any strenuous exercise, in particular like abdominal exercises with increased weight and or load would be an example. We do know that there are certain subsets of patients who are more prone to the development of an inguinal or a femoral hernia, those that are obese because their abdominal cavity is stretched and the tissue is just thinner, those participating in heavy lifting because they kind of do that Valsalva's maneuver where they're holding their breath and increasing the internal pressure. And then individuals who have been sick for an extended period of time, who have a extended cough, oftentimes will suffer from that inguinal, maybe even umbilical hernia. But what we do know is it's 5 to 7 times more likely in our male counterparts than not. So what are the signs and symptoms? You will see when they cough, a protrusion in the particular area of the herniation. They'll have pain with coughing, which is actually a special test that we can actually do. They'll have burning sensations in the area of the stretch, a sensation in particular with a direct inguinal and an umbilical hernia of feeling full. So what do we do for them? A surgical intervention is most often the case. And I'm going to skip to the slide to show you that you would do laparoscopic surgery, right? Very minor surgery with patients most often returning to play after about 3 weeks. So all in all, anytime we have an injury, an acute injury to the abdomen, big thing is keeping the airway clear. A key thing was treating for shock, especially with the risk of systemic infection. Want to arrange for transport, most often call to 911, but if it's even more emergent, maybe drive to the ER, record information, always everything that you've done. But the biggest thing that I always teach students is don't allow them to drink, to take meds or anything. The big thing is we want them to be able to go into surgery right away. And so we want to make sure that they don't have anything that would prevent us from doing that or allowing that. So there are things that can happen within the thoracic cavity and the abdominal cavity which impact the actual heart, which we haven't talked a whole bunch about. But I really love this sign. So this slide, I'm actually going to blow it up a little bit and like spend time kind of talking through this. So when we think about issues that can actually impact the cardiac component of our body, really kind of break them down into 3 different categories. So structural cardiac abnormalities, which are going to be things that you're typically, or you're born with. You can have electrical cardiac abnormalities, which means there's some disruption in the electrical component of the heart. You can have acquired cardiac abnormalities, and there are 4 different types: an infection that occurs, trauma, some type of toxicity, or type of environment can impact this area. So we have really 3 causes: something that's structural, something that's like a defect within the heart. Most commonly in athletics, that would be like a hypertrophic cardiomyopathy, where the external portion of the heart, the muscle itself, is enlarged, creating less ability for the ventricles to actually fill. A mitral valve prolapse, right, or aortic stenosis. Again, most often these are going to be congenital in nature. You can have a Marfan syndrome. So this is a patient who walks into your clinic and is like 7 feet tall, has long arms. Essentially what you're concerned with Marfan syndrome is going to be what have you all heard about Marfan's syndrome? Tell me. Anybody? Okay, well, Marfan syndrome is really of concern because it is a multi-systemic genetic disorder, and it really affects the connective tissue. The heart, in particular, the aorta of the heart is involved, and these athletes are at risk for suffering from an aneurysm. So oftentimes you'll have to refer these patients out to kind of get assessed. But some of the signs and symptoms, very, very, very tall patients, for example, oftentimes the eyes may be protruded out of the actual eye orbit itself. Individuals with Marfan syndrome typically don't have normal lung function. In fact, they might suffer from, remember we talked about spontaneous pneumothorax. And so there's lots of different symptoms, but these are going to be structural, right? These are all changes in the anatomy of the patient, particularly the cardiac region. On the electrical cardiac abnormalities, we have something called Wolff-Parkinson syndrome. Has anyone ever heard of that before? Wolff-Parkinson's White syndrome, which is where you kind of have extra signaling within the pathway between the heart's ventricles and atria. And so because you have these extra signals, it increases the heart rate or causes tachycardia in that particular patient. So most definitely can be controlled, but will have to be monitored most often. But where we're going to spend most of our time, right, as clinicians is in the acquired cardiac abnormalities region. So someone who has an infection of some sort, so a myocarditis or an inflammation of the myocardium, which is going to surround the actual heart and has an impact and can be life-threatening. Trauma, we just saw, right, the Hamlin injury where we had a direct blow to the chest, and most likely that patient was suffering from commotio cordis. Has anyone heard of that before? Well, if not, it is a condition in which a sudden blunt impact to the chest causes sudden death in the absence of cardiac damage. So in other words, like patient's completely healthy, takes a blow to the chest, and instantaneously they collapse on the field, right? And we can see that with Damar Hamlin. If you haven't, then you can have a situation where you have cardiac abnormalities that result from illicit drug use or performance enhancing drug use, and then environmental. So someone who is really cold or really hot, that can also have an impact. So we can see how there are kind of these things that all really overlap. At the center of it is the heart, and then it's just a matter of how the heart has actually been impacted. Either there's structural, there's impact to the electrical signals, or it's something that was acquired most often as a result of trauma. So I'll zoom us back out to say that we have non-cardiac causes, which we've talked about, and to be drug and illicit use. And then the things that we most often are going to see that patients are typically born with are going to be those structural electrical signals. So signs and symptoms, they may not exhibit any signs and symptoms. And I go back to Hamlin, right? Like, I'm sure he was healthy that day. I'm sure he had no chest pain that day. And here he is collapsing on the field. So you can have that where the patient just collapses. But then you can also have patients who report chest pain, right? After exertion, increases in heart rate or tachycardia, or some people might feel cyanotic and have bradycardia where the heart has actually slowed down. So we always want to ask historical questions. We want to ask familial history. That's going to be a big key thing. And then we want to prevent most of these things from happening. All of these things that I've talked about, prevention is the key. At the NCAA level, everyone actually goes through a cardiac screening. I'm not sure that we're there at the high school level, certainly moving there on the D2 NCAA level, but that is really the prevention, to kind of look at the heart and see if we can catch any of these electrical abnormalities or structural cardiac abnormalities that patients have that they're not aware of, right? So prevention is going to be the key here. So I hope this never happens to you, but there is this thing called sudden death syndrome. Males tend to be 3 to 5 times more likely to suffer from sudden cardiac death than female athletes. The data, like if we're looking at the evidence, indicates that Black athletes tend to suffer at a higher rate from sudden cardiac death syndrome than their white counterparts. In particular D1 basketball athletes. So Hank Gathers would be an example of that. If you've never seen that collapse on the basketball court, you should definitely take a look. But Hank Gathers would be an example of sudden death syndrome. Sudden death syndrome, if this ever happens to you, you should definitely receive counseling. But this is essentially what happens is the patient literally could be healthy, could not be complaining of any chest pain whatsoever, running up the court or the field and just collapses. You do everything you possibly can do, but unfortunately your attempt to sustain the life does not work and the patient typically dies. So there are a couple of things. Number one, our PPEs, our physical exams, are going to be extremely important here. Family history is going to be way key. The other thing that we started to do is screen the heart with an electroechocardiogram. This has been actually added to most D1 institutions, but it seems and appears that we might see it being more required of schools. So ultimately, what do? We're never prepared for this, but if we could look back at that assistant athletic trainer who literally started CPR right away, knowing your emergency action plan, what to do when something like this happens, is going to be key to the success of the athlete's life. Last but not least, here is the AHA's 14 element screen for patients when you're doing your PPE. So you're going to look at personal history, right? Familial history. You're going to look at physical exam. You're going to take all of these things and allow them to help you determine whether or not the athlete should be participating in sport, along with an EKG or an ECG. And these all together will help you determine who might be at risk for suffering from sudden death syndrome or from any of these three pathologies or at least abnormalities of the heart, which would increase their risk of sudden death syndrome on the field. So I would like to conclude this by just saying thank you for listening. I will see you in class.